5 minutes for questions, please.
Thank you, Mr. Chairman, and thank all of you for being here. Dr. Cerise, I want to start with you. As you know, HRSA uses a hospital's dish adjustment as dish adjustment percentage as one of the measures for eligibility for the 340B. And under current law, the hospitals must report the state of their low-income utilization rate in the inpatient setting and not in the outpatient setting. And of course, this can make a big difference. Simply put, the sum of the low-income utilization rate is an inpatient metric that is being used for an outpatient program. Can you tell me in your hospital, what's been your dish percentage for the last few years? You have any idea?
About 47%.
47% in the inpatient. Do you have outpatient facilities as well?
We do.
If you were to include those, do you have any idea what it might be at that point?
Yes, well, I can tell you approximately.
I understand. I won't hold you to
our
it.
Medicaid and uninsured percentages would go up if you included the outpatient.
The outpatient clinics?
Correct.
Okay. Dr. Daniels, what about you? Do you have any idea what your percentage is in the inpatient setting now?
The inpatient setting, we're at 34.77%.
If you were to include the outpatient, any idea?
I don't have that information. I know that we also do provide a high level of care in the ambulatory to Medi-Cal patients, and so.
Right.
But I don't know what the
Do
number.
you have child sites as well? Children's Hospital?
Yeah, we do
What's the
have-
patient mix there?
I don't have that information. We don't collect it that way, sir.
Okay. Dr. Cerise, do you?
In general, our child, we don't have children's, actually, we do see a little bit of pediatrics in our primary care clinics, but most of our child sites are serving adults, and the mix there is going to be roughly 75% Medicaid and uninsured.
So it's higher than in the inpatient setting in the hospital?
Sicker patients in the hospital, we tend to be able to get some coverage for sometimes better than the chronic patients we're seeing in the outpatient clinics, higher percentage of uninsured.
Well, and you know, I've got legislation that I'm introducing that would require would require the outpatient to be factored in as well, because I think that's very important. Because obviously, one of the abuses, it's not illegal. It's just one of what we consider to be some of us consider to be the abuses, is that a lot of the hospitals are using this in outpatient clinics and outpatient settings when it was intended to be used and based on the inpatient. So, Dr. Pat, if I could go to you, you talked about some of your experiences. They were really frightening to hear of some of the patients who are having to wait and are being denied care. And I was just wondering, what can you suggest that we can do so that this doesn't happen? So that some of these examples, what can we do legislatively in Congress?
So again, in my opinion, reform focuses around three issues: having transparency, accountability, and definition of a patient. So I think if you have transparency in how hospitals spend these funds, it helps to solve some of these problems immediately. And accountability, I think, rests in not just having this being a percentage dish metric for inpatients, but have some accountability for outpatients. Because this is really an outpatient program that's measured by dish inpatient. And again, if you look, as 340B programs have grown tremendously, 340B versus non-340B entities, on average, have only a 1% difference in uncompensated care. And so I think that we need to, again, transparency, accountability, and patient definition, I think, will bring up great actors in this program and give every hospital that's using this program an opportunity to provide excellent care to the patients they serve.
Great. I couldn't agree with you more. All three of those are extremely important, especially patient definition. To me, that would clear up so much about who is eligible and who is not eligible. Mr. Chairman, at this time, I would like to ask that this document titled "How Abusive the 340B Program is Hurting Patients" by the Community Oncology Alliance be submitted into the hearing record.
Without objection, so ordered.
Thank you. Let me ask you, Dr. Daniel, in your hospital, what qualifies a patient for a 340B?
First of all, they have to be under our care. That means that there is a relationship between the physician and the patient. Secondly, it means that they have to have been seen by one of our providers, and it means somebody with that contractual or employment relationship. And third, it relates to the encounter that generated the prescription being part of being seen in one of our sites.
Being seen in one of your sites, whether it's inpatient or outpatient.
It could be either,
It could be either,
yes,
but yet we base it on the inpatient.
yes.
Yes. That's, Mr. Chairman, I yield back.